Hello and welcome to the group room where we're at the 34th annual CTRC-AACR San Antonio Breast Cancer Symposium. Very happy to be joined again this year by Dr. Clifford Hudis, Chief of the Breast Cancer Medicine Service at Memorial Sloan Kettering Cancer Center and Professor of Medicine at Weill-Cornell Medical College in New York City. Hello, Dr. Hudis.
Hello. There was one more study looking at chemotherapy in metastatic breast cancer, and this study was sort of simple in its design. Patients got paclitaxel and bevacizumab, which of course is a hot button issue right now for many people, but they randomized these patients to get capecitabine with it or not. And that alone would be a simple question in the metastatic setting: are two chemotherapy drugs better than one? But it's confounded in an important way because the people who got capecitabine were left on it until their disease progressed. In contrast, people who got just paclitaxel stopped it at about 6 months because of concerns about toxicity. So while it's billed as a trial testing capecitabine, in fact it's a trial of giving chemotherapy to progression versus giving a fixed amount of chemo and watching. They all got bevacizumab until progression. And it was positive, but the point I think it really made, and we brought this out in the discussion, isn't really a capecitabine specific point. It's the point that many American clinicians treat to progression, and there's regular studies that show evidence that doing that prolongs the time until the cancer gets worse. That raises the sort of elephant in the room for all of us right now, which is the value of progression-free survival. And I made a point this morning, tangentially, without directly addressing the bevacizumab controversy, that the controversy really isn't about the drug. The controversy is about a total lack of agreement societally and from a regulatory point of view on what progression-free survival means. Because were we to agree on the fixed value of progression-free survival, then there wouldn't be any more debate about whether a drug should be approved or not approved when they have progression-free survival. So that was an opportunity to raise that interesting and unresolved question.
How does one begin amongst researchers to bring resolution to the question?
Well, it's really a kind of a mixed bag of issues, and I mention all this because so much of this comes up in the ongoing debate about the bevacizumab decision, but it comes up when others are talking about new drug development all the time. It would take a sit-down. It would take patient advocates who would argue or take a point of view on what PFS is worth. It would take medical oncologists and others who are treating these patients to argue about what it's worth. It would take regulators to come to some agreement that there's a threshold. But the other part of this is probably, if you were going to come up with a number, I could imagine that there's a number, 7 is good and 4 is not. Mm-hmm. But that number would have to probably somehow account for toxicity. Mm-hmm. And I personally would say it shouldn't account for cost, and I point that out because despite the popular press, cost is not an FDA issue. No matter how many times it gets repeated as such in the lay press, it isn't on their radar when they are making their decisions, at least not officially, and they're kind of barred from considering it. And I frankly think the evidence that that's true is pretty clear. They've approved many very expensive drugs even in the last few years. It's when the perceived value is low that the argument's thrown. So I think we could do this, but I think it would require a real combined effort. And then we would make peace with it, and instead of relitigating the question with each drug approval, which is where I think we are now.
And I appreciate that you acknowledge the influential role that advocates have in
I think patients, we can talk in abstractions, but objectively talking about what it means to not have your cancer get worse absent a survival advantage. That's the point here. Mm-hmm. That's a tough discussion to have, and I don't know that there's a wrong or right answer, but I do think that without agreement we are doomed to keep fighting it. Mm-hmm. And I think we could get past that, and then we would save our resources for something more. So that study gave us an opportunity to talk a little bit about that component of our current drug regulatory world.
Thank you, Dr. Clifford Hudis, Chief of the Breast Cancer Medicine Service at Memorial Sloan Kettering Cancer Center and Professor of Medicine at Weill-Cornell Medical College in New York City.
Thank you very much.
Thank you very much.